Okay, guys, this lecture is on spinal cord lesions. Spinal cord lesions are extremely important for the purpose of step 1 and step 2 and step 3. So I took some time to make a video for you guys. To understand spinal cord lesion, I think the best way to understand these lesions would be to understand the cross-sectional anatomy of the spinal cord. Now let's go into cross-sectional anatomy of spinal cord. This is a cross-sectional anatomy of spinal cord. If you look at it, you see the yellow area and a gray area. The gray area looks like a butterfly, and that is the gray matter. The yellow area that surrounds the butterfly, that's the white matter. Okay, now let's look at the gray matter first. So the gray area that looks like a butterfly is primarily made of cell bodies of a neuron. So if you look at a neuron, I'm sure all of you guys know anatomy of the neuron. Neuron has a cell body, an axon, and dendrite, and axon terminal. So the cell body is what makes up all the gray matter of the spinal cord. Okay, and usually it's unmyelinated. That's why it appears gray. Okay, okay. I mean, the gray area looks like a butterfly. So let's look at different parts of the butterfly. Let's look at this thin area of the butterfly. This is known as the dorsal horn. Okay, this is known as the dorsal horn or posterior horn of the gray matter. The dorsal horn of the gray matter is primarily sensory. What I'm trying to say is it only receives sensory information from the body. Okay, so therefore it's considered sensory and afferent. Afferent means receiving. It receives all sensory information from the rest of your body. For example, it receives information regarding pain and temperature from your skin. It also receives sensing position and vibration from your joints and fine and crude touch. Okay, so that's the dorsal horn. Now, if there's dorsal horn, there should be also anterior horn or ventral horn or frontal horn. Okay, this thick area of the butterfly, the thick end, which does not attach or which does not reach the surface of the spinal cord, that's called the anterior horn. Anterior horn is primarily motor and functionality, which means, and it's efferent because it sends information away from the spinal cord to the body. Okay, so it's strictly motor. Anterior horn is motor and it's efferent. Efference, think of it exiting. So neuron will exit out of the anterior horn and go supply your muscles, right? It's purely motor. So it'll supply your muscles. It's efferent. It's execute. In terms of its execution, in a way, you can think of it that way too. Okay. So the neuron that starts in the anterior horn and ends on muscles and other organs for the purpose of movement is called lower motor neuron. Lower motor neuron. Okay. When we think of lower motor neuron, I focus on number one, it's motor, so that's easy. It's neuron. Okay. The lower part I focus on. I'm going to color yellow. Why? Because it decreases everything associated with motor neuron. For example, it will decrease muscle size, it will decrease muscle tone, it will decrease muscle reflexes. Okay. All right. So let's look at it. Reflexes will decrease, so it will cause areflexia if there's a lesion of lower motor neuron. So lower motor neuron lesions can lead to hyporeflexia or areflexia, or decrease in reflexes. It also decreases muscle tone. Again, it decreases everything, so I'm going to color it, right? Lower, decrease. Decreases muscle tone, therefore it can lead to flaccid paralysis. Okay. It also will decrease muscle size, so it can lead to atrophy, muscular atrophy. Okay. It also decreases Babinski, so Babinski might be absent or normal. We will compare this to upper motor neurons, in which case everything will be elevated or increased. Okay, good. So really, really important to understand gray matter and different parts of the gray matter. Okay, so far I identified two parts of the gray matter, which is dorsal horn and anterior horn. But also I want to tell you this area. Let me change my color. This area of the gray matter. This is the posterior commissure. And this part is the anterior commissure of the gray matter. Okay. All right, let's go with white matter. White matter is the yellow area of the spinal cord, and it's primarily made of myelinated axon, as we discussed before. Okay. This area of the white matter with the green arrow is called the dorsal column. Dorsal column. Let's color it just so we can understand. Let me choose a different color. Let's color it. What should we do? Green? Yeah, let's color it green because it's green. So let's say this area, all of this area. This is the dorsal horn, dorsal column of the white matter of spinal cord. Of course, it has both sides, left and right dorsal column. Okay, it is really, really important for all medical students to understand this area. Okay, now the dorsal column is purely sensory. Maybe I should just let me give you a side note. When you think of the central nervous system, which includes the brain and spinal cord, generally overall, there are exceptions, but generally speaking, the anterior aspect of the central nervous system, spinal cord and brain, is mostly motor. And the posterior aspect or dorsal aspect of the brain and spinal cord is primarily sensory. So whenever we think of dorsal horn, dorsal column, we should keep thinking of it sensory. It's purely sensory. So what is it responsible for? What is its function? Its function is sensing position, sensing vibration, sensing fine touch. Fine touch, okay? So vibration, when you're sitting, you can feel the earthquake or you can feel the train going by. That vibration is sensed by dorsal column. Okay? Fine touch. Fine touch means like if you close your eyes and you touch and somebody touches your palm with a pin, with a sharp object and a dull object, you should be able to tell the difference. That's fine touch. Or sometimes it's called discriminatory touch because you discriminate between or tell the difference between sharp and dull touch. And that fine touch is the function of dorsal column. Okay? And then it's also responsible for sensing your position in space. Even you can be sitting down and you close your eyes, you don't see anything around you, but you still know you're sitting upside. You're sitting straight up. Okay? If you hang yourself by your feet like while you're doing gymnastics, you know you're upside down. So this sense of position, even you close your eyes without looking outside, you can still determine your position in space. And that is called proprioception. So sensing your position in space, that's proprioception, and it's the function of dorsal column. Very important because when you talk about lesion of the dorsal column, such as in tertiary syphilis, you should be looking for these things. Okay, all right. This area, look now. So that was dorsal column, but this area where the red thing is located, that's called lateral column. This whole yellow area. Let me just do this. All of this is the lateral column. Okay, lateral column. Now, let me erase this. So in the lateral column, there is a small part or region, which I represent by this red circle. This red circle is called the coracospinal tract. Coracospinal tract. Coracospinal tract is made of fibers, primarily of motor aspect. Okay, so coracospinal tract is strictly responsible for movement, voluntary movement. Now, when you get confused with these tracts, think of it this way. See, this coracospinal tract starts with which means cortex, brain, spinal second. The reason it was named that way because the tract starts from the brain and it ends in the spinal cord. So coracospinal tract, look at the name. It starts in the brain and ends in the spinal cord. Now, this tract carries fibers, wires, strictly responsible for movement. Okay, so what is the function of coracospinal tract? Movement. It's purely motor, and the coracospinal tract is made of upper motor neurons. Let's compare that to anterior horn, which is lower motor neurons, right? So upper motor neuron will increase everything. We will focus on what? We will focus on the upper part. So in this case, reflexes will increase, tone will increase, size of muscles will increase, Babinski will increase or upward. Okay, let's look at it. So upper motor neuron lesions will lead to, now look, if upper motor neurons and lower motor neurons are not affected, there's no lesion, there's no injury, they'll be normal. What I'm trying to tell you is if there is a lesion of upper motor neuron, you should expect hyperreflexia. reflexes should be increased. You should expect increase in tone, hypertonia. You should expect increase in muscle size, hypertrophy, muscle hypertrophy, right? Okay. And of course, increased muscle tone can lead to spastic paralysis or spasm. And this will cause Babinski increase, or the toe will be pointing upward. That's positive Babinski. Okay. Now let's look at it. This area of the lateral column, the blue area, which is also part of the lateral column, this is spinal thalamic tract. Look at the name, spinal thalamic tract, which means this tract starts in the spinal cord and it ends in the thalamus. Spinal thalamic tract is purely sensory. Okay, it's purely sensory. And the function of spinal thalamic tract is it senses pain and temperature. It is responsible for sensing pain and temperature and crude touch. Okay, so that is the function of the spinothalamic tract. Okay, so far I discussed three tracts, really important. Please understand dorsal column, purely sensory. Please understand spinothalamic tract, purely sensory. This is why I have blue and green, purely sensory, and coracospinal tract, which is purely motor, and red. Sometimes colors do help. Okay. Always compare coracospinal tract to anterior horn, which is the continuation of the coracospinal tract. Okay. Okay, but they're upper motor versus lower motor neurons. Okay, let's look at now part of the white matter. Okay, part of the white matter called the dorsal commissure. Dorsal commissure. This area. This is the dorsal commissure, which is part of the white matter. Okay, dorsal commissure is where the spinothalamic tract fibers crosses from left to right. Okay, so it is really important. So the posterior white commissure, again, make sure you read the title properly. It is not the gray commissure; it's the white commissure. The gray commissure is made of cell bodies. The white commissure is made of axons. Let me give you an example. Let me just draw something for you. Change to pen. Yeah. Okay. So fibers of spinothalamic tract. Okay. Fibers of spinothalamic tract. So spinothalamic tract fibers, for example, sensory information regarding pain and temperature will enter the gray horn, right? The dorsal horn of the gray matter, right? So this will be pain and temperature fibers entering the the dorsal horn of gray matter, and then as they go, they will cross over to the opposite side to the spinothalamic tract. Some fibers will go right here around the central, posterior to the central canal. Okay, they'll go like this, and some fiber will come anterior to the central canal. These fibers are called posterior white commissure and anterior white commissure. And then this fiber will be carried in the spinothalamic tract all the way to the brain like that. Okay. So let me tell you, this is anterior white commissure right here, the white area right here. Okay, so this is the anterior commissure. Anterior commissure carries fibers responsible for sensing pain and temperature for the rest of your body, and then they will cross over to the opposite side, and that's the important part. The reason I'm mentioning that because there is a disease called syringomyelia where the spinal canal will dilate and full of fluid, and it can compress these fibers. Okay, it can compress these fibers. Okay, good. So this was really important. I hope you spend time on this. If you know this, the lesion will become super easier. Okay, let's start with bilateral anterior horn lesions. So this is the cross-section of the spinal cord. Let's see, there are lesions of the anterior. Let me draw it for you. So bilateral. Let's do this. Highlighter. So bilateral. Okay. Why doesn't it turn? There you go. So the anterior horn is damaged. So the dark means damaged. Both anterior horns are damaged. So this is a lesion that occurs frequently or infrequently, I should say infrequently, not in the United States, but in some countries, because some infectious viruses, it can lead to damage of these areas. Okay, so bilateral anterior horn lesions, what could it lead to? This can lead to two conditions. One is poliomyelitis, and the other one is, um, let's go with this poliomyelitis. Okay, so in poliomyelitis, it's caused by viral infections such as poliovirus. Initially, poliovirus would cause gastroenteritis, and then the poliovirus can actually travel by retrograde axonal transport from the GI tract all the way to the anterior horn of the spinal cord, and it can cause degeneration of these bilateral anterior horn. Okay, so poliovirus infection will lead to, maybe it takes a few years, not right away, can lead to retrograde axonal transport. That's how it gets there. It's really, really important that retrograde axonal transport for the purpose of step one. Okay, and then it can cause degeneration of the anterior horn. Okay, now what do you expect? We know that anterior horns are responsible for lower motor neurons. If they're damaged, that means you will have lower motor neuron lesions on both sides, bilateral. Okay, depending on which level of the spinal cord. If this is T, thoracic vertebrae, will affect anything below that. If it affects the lumbar, which usually in this case it is, lumbar vertebrae or lumbar nerves, the lumbar spinal nerves, spinal motor nerves, then it will affect the legs mostly. So what do you expect if it's lower motor neuron lesions? Remember we talked about lower motor neuron lesions. In the case of lower motor lesions, we'd expect everything to be decreased. So there will be hypotonia, hyporeflexia, and atrophy. So hyporeflexia, deep tendon reflexes will be decreased, and I expect hypotonia, so flaccid paralysis, and I would expect muscle atrophy, so muscle wasting and weakness. Okay, and also Babinski will be absent or normal. Okay, Babinski is usually a sign of upper motor neuron lesion. Okay. So this is poliomyelitis. Your job is to memorize and understand that poliomyelitis causes degeneration, destruction of the bilateral anterior horn, which are lower motor neuron lesions. Okay, all right. Worst case scenario, what could happen? Your diaphragm is also made of skeletal muscle, so if diaphragm is not receiving enough impulses from the nervous system, it can lead to paralysis and eventually death due to respiratory failure. Okay, here is the picture of poliomyelitis patient. Look at their legs. There's no muscles, completely atrophied. So usually, as I said, it affects, because remember it starts from the GI tract. So the virus comes from the GI, it approaches the lumbar neurons first, or the lumbar spinal cord first. Eventually it can go up and up and up and cause worst case scenario, death by diaphragm paralysis. So that's one thing. So remember, polio is infectious disease. Poliomyelitis is as a result of infectious disease. On the other hand, spinal muscular atrophy is a genetic condition. Okay, genetic condition, and this is an autosomal recessive mutation of the spinomuscular gene. Okay, gene 1. And this gene is responsible for something called small nuclear ribonucleoprotein, which are responsible for splicing RNA. Now, if you guys don't know what that is, you should watch my genetic lecture. There you will find out spliceosomes are responsible for processing of RNA. It cuts it into small pieces, you remove the introns and you keep the axons, right? Anyways, so this is a genetic disease. Now, their question could, on spinal muscular atrophy, there could be a question related to the neurology aspect of it, which is bilateral anterior horn degeneration, or it could be, the question can be regarding genetics. So this is why this becomes high yield, because you can make multiple questions and ask for and test different disciplines. Okay. Anyhow, at the end of the day, it is genetic degeneration of bilateral anterior horn. Okay, genetic. Whereas in poliomyelitis, it was post-infectious degeneration, maybe like chronic inflammation, to some degree autoimmune. But in spinal muscular atrophy, it's genetic degeneration of bilateral anterior horn. So I don't care for, if I were you, I wouldn't care how the anterior horn are damaged. The result will be the same. Okay? So the result will be the same. It will be lower motor neuron lesions. It will lead to hyperreflexia. It will lead to hypotonia, and it will lead to atrophy, and it will lead to absent Babinski or normal Babinski sign. That's it. Okay. Worst case scenario will be the same, diaphragm paralysis. Okay. So in both cases, it's bilateral anterior horn lesions or degenerations. So one is genetic, spinal muscular atrophy is genetic, poliomyelitis is post-infectious in nature. Okay, let's show you a picture. Usually, spinal muscular atrophy, since it's genetic, it appears in children on birth, and you will see. Look at the bottom picture. The baby is unable to hold his head. You see that the head is pointing down. So because it has no tone, no strength. Right here, look. Okay, and here the baby is unable to hold his neck again and his legs. So they have no tone, no strength. So this is flaccid paralysis. Flaccid paralysis. Upper motor neuron lesions will give you spastic paralysis. One thing is there's another condition which is known as Lou Gehrig disease. Just I'm mentioning it now, in which you have both upper and lower motor neuron lesions. So pay attention to that. Okay, let's go with spinal canal expansion. So spinal canal expansion, this is the spinal cord, the cross-sectional spinal cord. So if it's spinal canal expansion, which means this area is the spinal canal, right? With the arrow, where the CSF will be flowing. So in the center of the spinal cord, there is a long canal, which is full of CSF or cerebrospinal fluid. Okay. What if, let me erase this, I made a mistake. Yeah. What if this area dilates? Okay. If this area dilates, so it expands. Here, I'm expanding it, expanding it, expanding it. You see? So if this happens, what's the big deal? What could it cause? It depends how far it goes, right? How much it dilates. You see that it is compressing the anterior and posterior white commissure. Remember, when you talk about anterior and posterior white commissure, we said that this is where the sensor information regarding pain and temperature will come and cross here and go up. And from this, they will come and cross spinothalamic tract and will go up. So at the end of the day, fibers right here are compressed. Okay? If the fibers there are compressed, that means the pain and temperature fibers will be compressed bilaterally because they cross right here. Not one side, both sides. So that would be a main thing to look at. Okay? And that condition is called syringomyelia. Okay? Syrinx or tube, myelia means it's myel, in this case means the spinal cord. Okay? So the syrinx of the spinal cord expands or dilates. Okay? Spinal cord aneurysm, maybe aneurysm is not the right term, but you can think of it that way. Expansion of the spinal canal or cyst formation of the spinal canal. Sometimes it could be due to tumors, right? It could be due to tumors. It could be, 90% of them are associated with Arnold-Chiari syndrome. Make sure you understand. So most of them are associated with spinal Chiari syndrome. Arnold-Chiari syndrome is where the brainstem and cerebellum herniates down through foramen magnum. Okay, so it can be caused by tumor and so forth. So what's the big deal? In syringomyelia, the white commissures are compressed. If they're compressed, that means the fibers that carries pain and temperature will be compressed bilaterally. Okay, so bilateral loss of pain and temperature. Usually the most common location, remember, look, if I were to draw spinal cord is long, right? So where is the dilation? Maybe it's just in this area. Maybe it's right here. It can be anywhere, right? But usually it affects the thoracic or cervical spinal cord. So it will affect the upper limbs mostly. It will primarily affect the upper limbs. Okay. All right. Mostly upper extremities. So anterior horn compression, if it expands, so if this expands all the way to here it involves the anterior horn tooth, then it can cause lower motor neuron lesion as well. So it depends how much it expands. Then you will have the same thing as before. Flaccid arm paralysis, bilateral arm muscle atrophy, hyperreflexia. Okay, great picture. Look at this. The area that is colored with red, this is the area of distribution of most common area where the syrinx will affect the pain and temperature fibers. Okay, so the person wouldn't be able to sense pain and temperature in the upper extremities and upper chest neck area. Okay, very straightforward, high yield. I had it in my exam, so you should look into this. Okay, what do we see here? Look at this picture. This is abnormal picture, and the red arrow tells you cerebellum. Cerebellum is herniated down. Cerebellum is herniated down. So that is Arnold-Chiari syndrome, which is in 90% of the cases associated with syringomyelia, right? In here, this arrow is showing you, the lower arrow is showing you the syrinx. Look, the spinal cord should appear dark, but because there's more fluid in this area, it's dilated, and you can see this white areas. Okay, compared to this area, look, with the blue line, this is dark. Above that is, with the red arrow, is expanded, full of fluid. You should memorize this picture and understand it. Let's compare it to normal. Look at the normal spinal cord picture. The whole spinal cord is nice and dark in the middle. There's no central hyperdensity. And then the cerebellum is in the right place. In the brainstem and cerebellum, they're not herniated down. Okay, they're way above the first vertebrae. Look, in here, they are right here. They're herniated down. Okay. So the green arrow tells you the cerebellum and the spinal cord, they're normal. But this, look for this. This is really, really important. Look for this. This will help you. Okay. Dorsal column lesions. Dorsal column lesions. We discussed dorsal column. Dorsal column is responsible for sensing, position, vibration, and proprioception, right? So what usually causes dorsal column lesions or degeneration? It's primarily affected by syphilis, tertiary syphilis, or neurosyphilis. Okay, so here we go. Now it will be damage to this area. This is the dorsal column. So degeneration of bilateral dorsal column is usually caused by, it could be unilateral too, but this could be caused by syphilis. Tabes dorsalis is the condition when it primarily or only involves the spinal cord. But if it involves other parts of the brain like meninges and brainstem above the spinal cord, then you can call it neurosyphilis, right? And it's tertiary syphilis. Just on the side, primary syphilis is the initial painless genital ulcer, followed weeks to months by rash and fever and arthritis and so forth, and then years later become tertiary syphilis. Tertiary syphilis includes CNS degeneration and aortic aneurysm or inflammation. Okay, so when I think of tertiary syphilis, I'll be thinking of CNS, especially the spinal cord, and aorta. Okay, so the bacteria is a spirochete, which is a spiral shaped bacteria, like this, motile, right? You can visualize this bacteria on dark field microscopy. Treponema pallidum, that's the name of this bacteria. Okay, so this question, you know that it could be high yield because why? It involves microbiology, it involves neurology, and it involves angiology, which will include the aorta. Aortic dilation or aortic aneurysm is a common complication of tertiary syphilis. In dorsal column degeneration is a common complication of tertiary syphilis. And then, of course, genital lesion and rash, look for those two as a primary, secondary syphilis. Tertiary syphilis take years to develop, so it wouldn't be right away. So you wouldn't find it mostly in children, it would be usually in adults. Okay. Dorsal column demyelination or degeneration is the end result of tertiary syphilis. Okay, so what happens? Well, if we know that, since we know that, we have memorized that dorsal column is responsible for sensing position, vibration, and touch. As a result, those functionality will be lost. So there will be loss of proprioception. Okay, proprioception meaning sensing a position in space. So as this could result in sensory ataxia. Sensory ataxia means that when you close your eyes and you walk, you won't be able to tell how deep the ground is. So you'll be very cautious to step and you're not able to walk nice and normal. So that's called Romberg sign. So Romberg sign will be positive because you lose the sense of position in space. Okay, so that's sensory ataxia. But it will also lead to vibration loss, sense of vibration loss, and you patient will also be unable to sense fine touch. Crude touch, which is by the spinothalamic tract, will be intact. So the patient can sense crude touch, but fine, sharp touches, they won't be able to sense them. Okay, especially if you want to discriminate between 2 points. Okay, but in the midbrain, there's an area called in midbrain called pretactile area. So sometimes syphilis can expand beyond or upward from the spinal cord into the brainstem, especially midbrain, and there it can cause demyelination of the pretactile area. So this can lead to inability to you can like your pupils will respond to accommodation but they will not be able to respond to light, and this is called Argel Robertson pupils. So accommodation constrict but not light. So in a sense that your pupils will not constrict when you flash light into it, but if you look in far in their object they will accommodate and they can constrict. Okay, so this is really really important. If it was me for the purpose of exam, even though this is not part of the Argel Robertson, where is my highlighter? Okay, even though this is not part of the spinal cord, it's extremely important. So these two things I'll memorize them definitely. You should see this on the exam. Okay, it's also associated with, right? Of course, syphilis or tertiary syphilis, neurosyphilis associated with urinary incontinence. Okay, it's also associated with psychosis, dementia later on. It can lead to Charcot joints. Joints are degenerated as well. They can be stabbing pain, thoracic aortic aneurysm. All of this should be associated with syphilis and look for those things. Okay, here this picture shows you secondary syphilis where you will see the rash, round target-like lesions, right? Erythematous, round macular lesions. Okay. Lateral tract demyelination. Okay, lateral tract, remember there were two lateral tract. One was the spinothalamic tract, the second one was the coracospinal tract. So in this case, lateral tract demyelination, what would cause that? Usually B12 deficiency. Okay, so if if you remember, let me see, I didn't draw it. Okay, so let's do this. If you remember here, let me get my pen. If you remember here was, what did I do? Remember here, this was the coracospinal tract, purely motor, and here was the spinothalamic tract. Okay, so B12 deficiency usually leads to combined degeneration. Combined, so it will lead to this lesion will cause combined this area like this. So it will lead to degeneration of or demyelination of both tracts. That's why it's called subacute combined degeneration. So focus on the term combined. Combined means both tracts, at least two tracts. Sometimes it's coracospinal tract and dorsal column. Sometimes it's coracospinal tract and spinothalamic. It's more common because they're close by. Sometimes dorsal column and spinothalamic. But it's combined degeneration. Look for that. And the most common cause of that is vitamin B12 deficiency. Vitamin B12 deficiency leads to methylmalonic acid accumulation, which is a toxic substance. The reason is because B12 is a cofactor for methylmalonic acid synthase. Okay. Okay. Hi, Dr. Ah, I'm recording this. Okay. So the next thing is it leads to dorsal column demyelination. When you lead to dorsal column demyelination, you know the functionality that's associated with dorsal column is sensing position, vibration, and fine touch. So all three of them will be lost or defective. Okay. So there will be sensory ataxia. We discussed that before. Vibration loss, fine touch loss, and then coracospinal tract demyelination will lead to upper motor neuron lesions, such as spastic paralysis, hyperreflexia, hypertonia, and Babinski sign positive. If you have this combination of symptoms, there's nothing else to choose. 100%. It would be B12 deficiency or subacute combined degeneration. But you should always be aware. See, B12 is so important on step 1. It is 1000% on your exam. B12, 1000%, you will see it on step 1 and 2 and 3. So the thing is, there could be biochemistry of B12, there could be neurology associated with B12, and there could be GI issues or physiology associated with B12. So you should know the cause of B12. Remember, it could be caused by something called um, gastric atrophy because the gastric cells, the parietal cells can produce it. So it could be intrinsic factor deficiency, it could be B12 absorption in the terminal ileum problem, Crohn's disease, it could be a flatworm or tapeworm that can start eating the B12. So there can be multiple causes, but know that B12 deficiency can result from multiple things, something called atrophic gastritis. Okay, it could be associated with that. In addition to that, B12 also leads to megaloblastic anemia. So I'll be looking for those things: megaloblastic anemia, diarrhea, in addition to the neurological symptoms. This is a picture of hypersegmented neutrophil. So this is the hypersegmented neutrophil. You can see it has multiple nuclei, which is associated with B12 deficiency. The reason is B12 is required for methylation of DNA nucleotide, and white blood cells that are produced frequently and faster, they don't mature properly without B12, so they can have immature neutrophils circulating, and that would be a clear sign. Let's go to the next, lateral tract demyelination. In this case, let's say there's hemisection of the spinal cord. So Brown-Séquard syndrome is when the entire one half of the spinal cord is damaged. Hemisection of the spinal cord. Okay, so that's what it is. The number one cause of hemisection spinal cord is like knife wound, sharp objects, trauma, bullets sometimes, but sharp objects. Okay, trauma is the most common. What do you expect? Well, in this case, everything is affected. All three tracts, dorsal column is affected, spinothalamic tract is affected, and coracospinal tract is affected. So if spinothalamic tract is affected, then I'll expect, because remember the fiber for spinothalamic comes from, let's say they enter right here, they'll go to the opposite side, right? So we contralateral loss of pain and temperature. Contralateral pain and temperature loss, right? And crude touch loss due to spinothalamic injury. If this injures your dorsal column, it will be ipsilateral sensory ataxia, fine touch loss, and vibration loss. And it can also affect coracospinal tract. You will have ipsilateral spastic paralysis, hypertonia, hyperreflexia, and Babinski. Straightforward thing, all these symptoms should be below the level of lesions. Okay? Okay. Here's the picture. And you can see, usually if they show you a picture, you will see multiple fractures. Usually the vertebrae will be fractured, otherwise you will not reach the spinal cord, right? The spinal cord is protected by the vertebrae or spinal column. So look for that.